of organizations, the events of the past year have heightened our awareness of the impacts of systemic racism. As a healthcare company, these impacts are clearly visible in the distribution of health outcomes across our diverse patient population. Tandem wants to add its voice to those who are speaking out, to advance the conversation, and to promote action to address this critically important issue, not just for our own patients, but for society as a whole. So with no further ado, I'll turn the presentation over to Melissa Hurd, the HHS Region 3 Executive Officer. Thank you.
Thank you so much, and good afternoon. Thank you, Reverend Bird, and to Jermaine Brumell for extending this gracious invitation to participate in this forum. I am delighted to be here this afternoon, and I'm here today to highlight the work that has been done in the spirit of collaboration with our faith and community partners, particularly as we fight to conquer COVID-19 and other pandemics. First, let me start with some good information. I'm happy to say that over 200 million people received at least one dose of the vaccine in the administration's first 92 days. This is ahead of the administration's schedule, and so this is an amazing accomplishment. As you are aware, HHS worked tirelessly to combat this disease in 4 different ways. Number 1, by working and employing our community health centers, working with retail pharmacy programs, our mobile sites, and our community vaccination sites, or the FEMA-run sites. Through the hard work and dedication of staff, community workers, and others, we have, in fact, vaccinated, more than 51% of all adults. They've gotten at least one shot. More than 80% of our seniors have gotten at least one shot. And you know, nearly 2/3 are fully vaccinated. And seniors, unfortunately, accounted for about 80% of COVID-19 deaths. 80% of our K-8 teachers, school staff, and childcare workers got at least one shot by the end of March, and schools are reopening across the country. This is remarkable progress, and progress that has already saved thousands of lives. It is a direct result of the aggressive action taken by the administration, the Biden administration, our whole of government response, and millions of Americans who have come together to get vaccinated. That's not all that we're doing. We're also creating more places for people to get shots. We've provided over $4.7 billion in 58 states, localities, tribes, and territories to support and increase vaccination efforts. We provided over 900 community vaccination sites with federal support, federal personnel on the ground at nearly 500 community vaccination centers and mobile sites that I mentioned earlier. We've stood up 37 high volume federally run sites to date and have already administered over 4.1 million total shots in some of America's most disadvantaged neighborhoods. And when we're talking about health equity, we're not just talking about race, we are also talking about urban versus rural. So to that point, we have provided federal support for more than 500 mobile vaccination pop-up clinics at high-risk communities, including rural areas. Now, what are we doing to establish an equitable response or approach to vaccines for COVID-19? Just to give you some information, and you'll hear more from our keynote speaker. We've delivered about 4 million doses to 650 community health centers, and 70% of those doses were administered to people of color. We've administered over 4.1 million total shots through federally run community vaccination centers in high-risk communities. We've expanded, of course, our federal pharmacy program to over 30,000 activated stores. And we provided $100 million in funding to help community organizations assist at-risk seniors and people living with disabilities access vaccines. While COVID-19 has been perhaps the most talked about pandemic, we recognize it is not the only one. Those of us who have worked in public health know that health disparities are still plaguing many people in Black and brown communities. In HHS Region 3, based right here in Philadelphia, we have created the Regional Health Equity Council to work with both our federal partners and our community and faith-based partners to shine a light on these disparities. Many of them you will hear about more from our guest speaker and the panelists. These disparities tell the true story about healthcare in our country and in this region. The Regional Health Equity Council convenes on a bi-weekly basis to pool the collective assets of the federal government in areas of Medicare, Medicaid, programs for older adults through our Administration for Community Living, federally qualified health centers, the Administration for Children and Families that oversees our Head Start and TANF programs, and even the Office for Civil Rights that works tirelessly to see that equity is achieved through policy that affects people who are disabled and discriminated against based on age, race, gender, sexual orientation, just to name a few. Let me end by stating that the Regional Health Equity Council is here to work in partnership with you. We know that the federal government cannot solve all the problems of this country, region, or city, but what we can do is our best to provide resources and information to communities in need that can assist with reducing barriers to access and putting equity at the forefront of everything we do. Thank you so much, and I look forward to hearing more about what's happening with regard to the forum.
Thank you, Melissa. Mark Osterberry here. I get the distinct honor to introduce our guest speaker today. Roslyn Holiday-Moore. She is the Deputy Director for Programs for the Office of Minority Health. We use an acronym OMH at the HHS. Ms. Holiday-Moore oversees all program development and implementation of activities at OMH. Prior to joining OMH, Ms. Holiday-Moore served as a senior public health analyst in the Office of Behavioral Health Equity, again, another acronym OBHE, for the Substance Abuse and Mental Health Service Administration, SAMHSA. OBHE coordinates SAMHSA's effort to reduce disparities in mental and substance use disorder across all populations. As the senior staff, Ms. Holiday-Moore provided guidance and direction on national policy, program, data initiatives that address health disparities and promote health equity for underserved individuals and communities. She's done this work in several ways, increasing the availability of cultural and linguistic appropriate behavioral health care, analyzing data to predict populations' health risks and inform resource allocation, networking community leaders to expand linkages and services delivery capacity, train principles of inclusion to improve health outcomes for individuals living in narrow margins of society. Before becoming a federal employee, Ms. Holiday-Moore held leadership positions in the children's mental health for the New York State Office of Mental Health, New York City region, including serving as the Director of Community Services for the Bronx Children Psychiatric Center. Though her work for the New York State Research Foundation, she directed the Family Reach in individual new. Sorry about that. She directed the Families Reaching in Every New Direction. Again, another acronym, FRIENDS system of care in the South Bronx. The project demonstrated cost benefits and improved health outcomes for communities serving the children. Ms. Holiday-Moore earned her degree in speech language pathology at Queens College, the City University of New York, Teachers College, Columbia University, and is a licensed speech language pathologist. Please join me in welcoming our speaker today, Ms. Holiday-Moore.
Thank you so much for that kind introduction, and most importantly, for the opportunity to join you for today's discussion sponsored by Forum Philly and Tandem Health. I am very excited to be here and privileged in knowing that the messages that we are promoting through the Office of Minority Health are also being well received in localities such as yours. And I affectionately reference you as a city of brotherly love, knowing that that love is reaching far beyond the localities in which you sit, as well as where I'm sitting. My apologies for all the acronyms. I'm going to try very hard to use real words and how I frame my remarks. But at the top of the discussion, I'd like to share a thought that came to mind when I was preparing for this. And it's really 2 lines from a song that I think are most important for framing the intention and the what I hope the follow-up from today's dialogue. And the first goes, if not now, when? And if not now, don't keep making promises. Mm-hmm. I ask you, if it's not now for you, maybe this isn't the discussion either, because I am really about bringing action forward and making sure that what I share with you and what I bring from the Office of Minority Health is not about a promise. It's about turning our reality into a better tomorrow. As I think about the work we're doing and where you are, I think of partnership, key. And what better way for me to start with acknowledging our new Assistant Secretary for Health, Dr. Rachel Levine. Many of you know of her, who was formerly Pennsylvania's Secretary of Health. We are really excited to have her join. And in joining, we are also at a place of saying, this is a hopeful moment. It is a time that we are transitioning from a very long, challenging year to a place where we can have increased vaccine supply and eligibility. As you know, in January, President Biden signed the Executive Order 13995 to help ensure an equitable pandemic response and recovery. That executive order led to establish the HHS Health Equity Task Force that my office currently supports and coordinates. The task force is part of a government-wide effort to identify and eliminate health and social disparities that result in disproportionately higher rates of exposure, illness, hospitalization, and death related to COVID-19. I want to have everyone mark your calendar if you can. The task force next meeting is tomorrow afternoon. It will be live streamed on the HHS Studio channel. And I invite everyone to go to the Office of Minority Health website at minorityhealth.hhs.gov for information about viewing. Increased vaccinations, of course, bring us closer to a time where we can reunite with friends and family safely. It is also essential for us, though, to focus our efforts on ensuring that our response is equitable in all communities and sustained. Communities of color experience drastically worse outcomes from COVID-19. That's not news at this point. We know that African American and Latino populations are more likely to be hospitalized and more likely to die from COVID-19, according to CDC data. Because of this, equity must be at the center of this administration's response It must be at the front and center of all of our responses, including the use of contact tracing, testing, and now vaccine distribution. Marginalized and minority communities are often the first to be forgotten, especially when resources are in short supply. We remain committed to disrupting that narrative and making sure we are changing the story for all those who have been struggling over this pandemic. That means prioritizing access, making sure that vaccines and other essential medical services get to the people who need them the most when that need is greatest. To help meet the demand, we are moving forward with ensuring eligibility is met with availability. The administration is expanding the pool of qualified professionals able to administer shots to arms to include dentists, optometrists, paramedics, physician assistants, and many more, including trained medical and healthcare students. Alongside this effort, the Department of Health and Human Services will launch a new portal to help individuals determine where they can sign up to volunteer to administer shots. As we continue to fight against centuries of structural inequities, we must be intentional about the ways in which we are making vaccines accessible in an easy and convenient form for everyone. Key to that effort is working with community-based organizations and having enough vaccinators to deliver shots into arms. So I encourage healthcare providers participating in this forum to visit the new portal at phe.gov, check your status, and sign up to help. This is an opportunity, and thank you in advance for taking advantage of that. We also know some communities need more support, especially as the work to increase vaccine confidence continues and expands across all the diverse neighborhoods that we know are still needing additional support. In fact, partnerships and work at the community level are more important than ever as vaccines become more available. As we know, vaccination is vital to stopping the pandemic, but it only works if the vaccine is accessible. The federal government is committed to a data-driven strategy to target vaccines for those communities that face the most substantial issues with availability and access. To reach the hardest hit and highest risk means working for equitable access to vaccines on all levels, federal, state, local, and across community and private sectors, including healthcare providers, community, and faith-based organizations. Many of us at the federal and local levels have focused for months on improving vaccine confidence in the communities we serve. After a long period of seeing troubling data about health disparities, including disparities experienced by African American and Latino populations, there is reason for optimism. According to a recent report, 14% more Black adults are saying they want the vaccine or have already been vaccinated. And the gap has closed considerably between African American adults and Latino and white adults. I don't think we would have seen that improvement but for the participation of community-based organizations throughout the country, including faith leaders, health advocates, local healthcare professionals, and everyday people who are deeply caring about the health of their families, their neighbors, and their communities. At HHS, an important part of our focus has been on understanding the perspectives of people in what's known as the movable middle. Individuals who are hesitant about COVID-19 vaccines, but remain open to the idea. We recognize that trust in healthcare and vaccine confidence, particularly within communities of color, must be rebuilt or in some situations, established. Trust must be earned through word and action. An important part of building confidence in the vaccinations and in the healthcare services that surround them is understanding how we connect with individuals and that we make that connection so that it's authentic and culturally and appropriately and linguistically appropriate in its alignment. When we are open-minded, that means it goes both ways. Communities are now more open to information that they are receiving, and we at the federal level are more open to learning from communities. That two-way street marks success. Many people have questions, and we want to be able to provide answers. We're finding that the direct connect using trusted messengers is one of the key ways for that to happen. Last month, the Office of Minority Health announced a $250 million grant program to help local governments enhance COVID testing, contact tracing, and vaccination for racial and ethnic minority and socially vulnerable communities. The application period has closed, and we're very excited about learning more about the applicants themselves and advancing the work. We're aiming for the end of June, with starting in July with at least 73 communities divided between urban and rural settings. This initiative is expected to help us demonstrate the effectiveness of evidence-based, culturally and linguistically appropriate health literacy strategies aimed at improving the access and use of COVID-19 testing, contact tracing, and vaccination. We also understand that when we are providing this level of support, health literacy creates a sustained platform for improving health and wellness over time. It helps us create an environment for addressing disparities that pre-existed COVID-19 and unfortunately may exist beyond COVID-19, because this is not a new situation that we're facing, but it does create an opportunity for us to align our efforts so that we can create new possibilities for solution. I also want to bring attention to two other key OMH initiatives that began last year and are now taking root in a way that we are very, very encouraged by. The first is a cooperative agreement with the Morehouse School of Medicine that provides key partnerships with African American, Latino, American Indian, Alaska Native, and Asian American and Pacific Islander organizations. Morehouse School of Medicine operates the National COVID-19 Resiliency Network, also known as the NCRN. The NCRN has both national and local reach, utilizing trusted voices of influence within communities, including work with promotoras and promotoras de salud. The NCRN has recently launched a new platform that allows any individual to put in their zip code, and with that information, you are able to access resources related to COVID-19 in your neighborhood at a glance. It should take less than 2 minutes to find the resources that are available for you. For some of the partners within the NCRN, they are focused on delivering messages that are tailored to make sure they are in language, but not just language, are also culturally framed. We're always looking for new partnerships in this space. And if there is an interest, you can go on the Office of Minority Health website and sign up to participate in the ongoing and growth of this network, and to ensure that the communities you are representing are well represented in our space. So again, this is a part of that two-way path where we are extending resources, but we also know for those resources to be most effective, we also have to learn from the communities in which we are trying to provide support. Given where we are in partnership, we're also looking deeper within localities. We have now engaged the 100 Black Men of America in its 98 chapters and you need those, and it's 278 local affiliates to support the work of the NCRN. And again, this is an opportunity where we may not know of all of the local networks and you know a lot more. Please share them with us. Please help us build this network so that it's most relevant. And I just want to give a quick plug for your local Health Equity Council, because if there is a way that you can leverage that council to help the Office of Minority Health, which is a little bit further from you, reinforce our relevance and our responsiveness, I encourage you to take advantage of this moment. Your council was one of the first in the nation. So that means you are both thought leaders and action oriented. That's a good combination in this pandemic as it's moving towards a place of resolution. I'd also like to focus attention on another initiative. And it's an initiative that I think will have long-standing impact. Given the high blood pressure, the connection of high blood pressure and where it's not controlled as a comorbid or a place of increasing risk around COVID-19 outcomes, we have the hypertension initiative that is using smart technology to help individuals better monitor their blood pressure. And as we are bringing awareness around the alignment with pre-existing conditions that may make managing COVID-19 symptoms more challenging, we're also mindful of this long-standing disparity. So we're hoping that the initiative not only improves COVID-19 outcomes, it also creates the stage by which we can increase awareness around the disparities that have been experienced with hypertension. So with that, I also want to kind of change the focus of my conversation to what's happening within Philadelphia and the surrounding areas, because it's nothing short of impressive. Long before I accepted this invitation, I was seeing work emerging from your communities that, again, were in the forefront of attention because you were setting the stage for others who are looking for solutions for engagement and ways that partnership with communities could be more effective. The Black Doctors Consortium, definitely in the forefront. It has been a high mark of how work in tandem with community leaders can be most effective. And you have done nothing but rise in that space. Philly CVC, so sorry, I'm so used to going to CVS. CVC, again, setting the stage for what is now becoming a best practice of having walk-in sites. Where I am here in Maryland, there was, I want to say that they copied your model where they're having something similar in a local mall where they are capturing people walking in. And it's a store that had closed because of the pandemic. Now they're able to repurpose that space. Not different than the leadership that you have already established. Esperanza, similar impact, where you are offering people access to vaccination in the way that they can receive it. And so the numbers, 1,000 shots per day, 6,000 shots per day, that is amazing, not to be underrated in any respect. And so highlighting it here is a way of saying thank you, but it's also a way of saying, know that your work is seen around the country and being used as a model for improving outcomes for others in similar situations. I've already done a shout out to your local Health Equity Council, but it's not just to say, because I want to congratulate Melissa and her team for doing a good job. It's because it's our collective responsibility to make sure we are lifting everybody up. And so in lifting up best practices, I also want to acknowledge the opportunities we have. We're coming to the end of April, but it is National Minority Health Month. Every month can be National Minority Health Month. As a nation, we know that is our responsibility and our opportunity. So being vaccine ready in April means you can be vaccine ready moving forward. Please, if you have not at this point gone on our website, go to our partners page and make sure that you are leveraging the resources that we're making available to you. I'm sure they are available through your Health Equity Council as another pathway to accessing information. We want to make sure that vaccines are safe and free for everyone. Some of the recent information about how there's been a pause and now we're back on track. I'm sure there are questions that are coming through around that. Well, we want to be able to be responsive and make sure people understand attention is being placed to make sure everyone is getting what they need in a way that's reasonable and in a safe and healthy way for them. We think that as we are moving forward being vaccine ready, we're also recognizing there are other areas of work that need to happen. So along with sustaining our focus on readiness, we're also going to leverage next month, which is Asian American Pacific Islander Heritage Month, as a way of staging conversations and being more transparent about work to address the increasing rates of violence and discrimination against Asian American and Pacific Islander communities as a part of the outcomes of this pandemic. It's unfortunate, it's been painful, but it doesn't mean that we can't do something as a collective to change the narrative. There will be a series of conversations, but I want to point out one that will be happening on Saturday, May 8th. It's a Saturday, believe it or not. We are actually framing something that can be accessible for everyone. And we have partnered with the National Park Service and the White House Initiative on Asian Americans and Pacific Islanders to host a panel discussion, past and present, addressing racism and intolerance against Asian Americans. The event will be from 2 to 3:30 p.m. Eastern, just in case you have friends and relatives in other time zones. And we will have information on the OMH website to help you connect. It will be a virtual event. But I think it's a time that we can share not only the data and policy points, but also the practical strategies to bring awareness not only to our current experiences, but the way in which history can inform how we move forward in a better way. We don't want to repeat things that have not gone well, but we do want to strengthen and reinforce the best of what we do. In closing, I'd like to ask one thing, just one. Please do not let this be a one and done moment. Please do not let this time pass as if we have not had a meaningful opportunity for leveraging partnership and resources to be helpful in ways that we cannot imagine. Collectively, we will change the experiences of everyone in this country, especially those populations who are in the margin, who are socially vulnerable, and who have historically not been included in the mainstream. Thank you again for the time to be with you. And if possible, I can entertain questions, or if your agenda is so well packed, which I'm sure it is, I will just join the other panelists and be a good listener. Thank you again for your time.
Ms. Holiday-Moore, thank you for sharing all of those great initiatives from the Office of Minority Health. Thank you. And I would like to thank Forum Philly for inviting me to introduce our moderator. I am grateful to be a part of the Enon Church community, which works to address health inequities and health disparities in the community. Reverend Dr. Alan E. Waller is the senior pastor of the Enon Tabernacle Church in Philadelphia, Pennsylvania. Dr. Waller is a highly sought after revivalist, vocalist, and lecturer. He is a true visionary of the church and community who serves humanity far beyond the restraints of traditionalism. His partner in marriage and ministry is Dr. Ellen Jo Waller, the leader of Enon's Women's Ministry and a devoted mother to their two daughters, Ellen Morgan and Erica Lynn. At Enon, understanding that the body is our temple and that healthcare is of paramount is emphasized. There are ministry events that address the trauma of cancer as well as assistance for those that are caregivers. In addition, the Know Your Numbers annual event that was initially geared towards men was expanded this year since everyone needs to know the basics. So it goes without saying that with the onset of the COVID-19 pandemic, Pastor Waller converted the parking lot at the East Campus into a testing site in collaboration with the Black Doctors COVID-19 Consortium. He understood that the need was great. In continuing with facilitating solutions that are beneficial to those in need, COVID vaccinations are available every Tuesday in partnership with Einstein at the East Campus, since vaccinating the most vulnerable is the next step in eradicating the virus. As a leader, you often have to step out on faith, and Pastor Waller doesn't have a problem doing what is right, even in the face of tremendous odds. Thank you, Pastor Waller.
Thank you, Dr. May. Thank you with Philly Forum. Thank all of you for being a part of this most necessary conversation. Again, we want to thank Dr. Roslyn Moore for her comments and for setting the agenda for our conversation today. I am honored and grateful to be a part of this conversation, at least to throw the questions in the air so that our expert panel can help us appreciate what we are wrestling with. You know, it has been said that when America has a cold, the Black community has pneumonia. The reality is this pandemic has not as much done something as it has revealed something about the state of healthcare and about the state of health in general in our country and in our community. So I'm grateful today to introduce to you 4 persons that will help us think through this conversation about health disparities. First of all, we have Dr. Natalia Ortiz, who is a professor of clinical psychiatry and behavioral science, the Lewis Katz School of Medicine at Temple University, medical director consultation and liaison psychiatry at Temple University Hospital, and president of the Philadelphia County Medical Society. Dr. Grace Ma, who is the Associate Dean for Health Disparities and founding director for the Center for Asian Health, in the Lewis Katz School of Medicine at Temple University. Dr. Michael Johnson, who is the founder and medical director of Miriam Medical Center, and Frank Ngari, CEO of Tandem Health. Thank all of you for being with us today, and thank you for agreeing to help raise the collective consciousness of our community around this issue of health disparities. What I'd like to do is level set in this moment, and we have about 40 minutes to have this conversation. And I'd like to level set so that our listeners will understand just what we're really talking about. So I'd like each of you to begin by helping us to understand how are the terms health inequities and health disparities defined by health professionals, and what are examples of both? Now, what I'd like to do is just go in that order, beginning with Dr. Ortiz, then Dr. Ma, Dr. Michael Johnson, and Frank Ngari in that order. How are the terms health inequities and health disparities defined by health professionals? What are some examples of both?
Well, thank you very much for the invitation, Mr. Waller, Dr. Waller. So the health inequities are like systemic differences in health status and distribution of resources to different population groups. health disparities are health differences linked to social economic disadvantage. Example, I can give you a quick example if I have a little bit of time.
Mhm.
A story of a friend of mine, moved from Puerto Rico. I won't give any names, but it's in the 40s. So moved around 10 years ago. Had an accent. Spanish is the main language. He was a person who had a managerial job in Puerto Rico. Economic crash in Puerto Rico. We know about a lot of problems that we are facing there. So he decided to move to the mainland and then look for a job. Found had difficulties because of his accent and the grammatical errors. Finally, decided to start working for retail, lower paying job. He enrolled his insurance. He had to make a decision in between paying the copayment to see a physician for maintenance of high blood pressure that he had and hypercholesterolemia, high cholesterol. He decided not to continue following up. It was too expensive. He needed to pay the house of the mom in Puerto Rico, and he needed to pay his expenses in the mainland. So eventually what happened? He had a heart attack and he had to make a decision. So he got the treatment for the acute problem, but then he needs maintenance treatment because he developed problems with his heart, meaning congestive heart failure, when the heart doesn't function to the 100%, doesn't pump blood to 100%. He didn't understand exactly the medications that he was taking, and he thought that it was okay to take them as needed, as he could have financially afford them. So what happened? His heart started to slowly weaken to a level that is functioning to a 10%. He still works, and I'm proud of him. I cannot believe how come he can work. It took several conversations to convince him of his denial, but he was focusing on finances. He had a lot of pressure and he had to make decisions. Food, difficulties with the food, affording apartment, paying for money, paying for expenses of the family. We are Latinos, we take care of our families. So health inequities there, language barrier, access to a affordable health insurance that will cover his medical conditions. Gotcha. And financial limitations. That's an example on real life.
Thank you so much. Dr. Ma.
Thank you, Dr. Ortiz and Dr. Waller, for your invitation. It is my honor to be part of this panel discussion. The terms of health disparities and health inequity oftentimes are used interchangeably. Basically, they describe the health differences that are unjust and unfair. Oftentimes, they're linked to social, economic, and environmental disadvantages. For example, African-American men are 70% more likely to die from a stroke as compared to non-Hispanic white. Almost 2/3 of Filipino Americans have high blood pressure, and many of them are having uncontrolled high blood pressure. African-American adults, they're 60% more likely to have diabetes as compared to non-Hispanic white. So the Asian populations have similar disparities in terms of liver cancer. Asian Americans are 60% more likely to die from hepatitis B related liver cancer as compared to non-Hispanic white. So these are just a few examples of statistics in terms of health status. But of course, they're linked to many other social conditions, social determinants of health. As Dr. Ortiz mentioned, it could be socioeconomic status and race, ethnicity, immigration status, structural racism, or implicit bias that limited their access to healthcare, and also have a complete, more adherence to follow up on the treatment, etc.
All right.
Thank you.
Thank you. Thank you, Dr. Ma. Dr. Johnson.
Well, I think to start off, talking about healthcare disparities and inequities, we have to look at the entire healthcare system. The entire healthcare system is sick. It is, and the players in it, the healthcare providers, the insurance companies, the hospitals, the pharmaceuticals are all part of this illness. And what happens is those who are at the bottom rung, and mainly, we see it mostly in the brown and black and Hispanic and other color populations, get the brunt of it, but it's across the board. So when those at the upper level, those at the upper income start to experience it, then we start looking at, well, maybe this is not just a problem of those, it's a problem that is manifest everywhere. So the bottom line is the entire healthcare system is sick. COVID has just revealed how sick it is for those at the bottom rung. And this is nothing new. This is nothing unheard of. We ignored it until this present pandemic. And so we live in a system, this capitalist system, that we have not learned how to define or really learn to appreciate. When are we going to look at costs versus revenue? Our healthcare system is designed to emphasize revenue, how much they take in, and our healthcare system, all the players that I mentioned above, the pharmaceutical industries, the hospital, et cetera, even we as physicians are more concerned with the revenue and than we are with providing services. And so it has this basic effect on those who are at the fringes, and that happens to be people of color, Asian, Latin American, and of course the impoverished white. And so this hits anybody who will recognize that our entire healthcare system is sick, and until we rectify it, all of us will continue to pay, because the players involved are more interested in what is beneficial to them than is beneficial to the people they are called to serve.
Thank you for that, Dr. Johnson. CEO of Tandem Health, Frank Ngari, how do you weigh in on this conversation? I think he's gone.
He's muted.
Corey, my bad.
Okay.
Thank you very much. I can only add to these great insights, and I'll just start by saying this identification of what's been revealed is so powerful. And if we can turn that revelation into awareness, that would be powerful. The healthcare system is sick, partly because how it fits into the entire system. We are the only advanced country in the world that thinks that healthcare is a cost, that it is a privilege. Every other advanced country in the world thinks that healthcare is a right and an investment. And the fact of the matter is that whether you're a capitalist or socialist country, investing in the health of your population is good business. It's smart. We should be doing this for every good reason. This is the place where morality and economy share the same footing. So to me, health disparity and health inequity is so interesting. It's both a cause and a result of other inequities. It's a part of a cycle, and we have to change the cycle. And I'm honored to be a part of this group, because I think one of the things that happened in the past year is the business community realized it can't be a passive observer of the change, that we have to go beyond saying we have a diversity program and we're going to do minority hiring. We have to say out loud, we're going to become anti-racist. We're going to participate in active change. We're going to try to change this dynamic. It's not enough to mouth platitudes. To me, health disparities show up first in access. People can't get access to care.
Mhm.
Secondly, they can't get access to accuracy of diagnosis. They don't get the same quality of testing. Third, they don't get access to the same quality of treatment. The truth of the matter is that the same treatments are not applied to all people with the same diagnosis. There are expensive treatments and there are cheaper treatments. Not that the expensive treatments are always better, but the poor do not get the same access to the variety and range of treatments. They don't get the treatment at the same time. Minority communities get treated for disease later in the process. And the fact is, our country is in the grips of chronic disease, which becomes acute. And to your point, Dr. Johnson, we have a system that is willing to pay for the amputation of the feet of a diabetic, but is not willing to pay the primary care doctor enough time to take off grandma's shoes and examine her feet. So this disparity runs across the board, from access to the timing of care to the quality of care. But I do think that there's a tremendous hope, which we heard in our keynote speaker today, which is this is not a battle between what's good for the country economically and what's good for people because we should take care of people. This is the same goal. We should invest in the people, because if you don't, you get the other inequities. People can't go to work. They can't raise their children. So I hope we can finally use this year to realize we have shared goals. Thank you.
Thank you. Thank you for that. So I want to drill down a little more, and we'll be a bit more specific with a couple of you. So we know that it exists, health disparities by your definition, and inequities. But Dr. Ma or Dr. Ortiz, what are the understood variables for the persistence of the health inequities and health disparities in the Philadelphia region? So in general, we know it exists, but from your perspective as a professional, what are the understood variables for the persistence? I mean, we know it's there, but it just keeps on happening in our area. How would you answer that, Dr. Ma, Dr. Ortiz?
Yeah, I wanted to re-emphasize that the social determinants of health that actually lead to the disparities in health and healthcare. Why communities of color getting less preventive care and less quality of care is because of these disparities. They're not available. They're not accessible, the services, and oftentimes they could be not acceptable. So the 3 A's are very, very important for quality of care. If they're poor, they just can't afford higher, better health insurance. If they're poor, they were going to hesitate to go to visit doctor because they can't afford the copay, or the deductible is too large. And they will wait till in the advantage condition, they end up to be in the emergency room. So that's where a lot of persistent issues, language issues. You know, I work closely with Asian American communities, and we don't have culturally, linguistically appropriate services because the health system would lose money if they hire patient navigators or help, or the phone translation doesn't work. You need actual bilingual, multilingual patient navigators to navigate them throughout the health system. They can't even make appointment because they don't know the language and they don't know how to get from primary care to the specialty care. So the coordination of care is a very, very challenging to these populations. So I would say, go back to your question, would be social determinants of health. All of these matters. Thank you.
Thank you for that. Dr. Ortiz, do you have anything?
Yeah, the poverty rate is 23% in Philadelphia. 40% of Hispanics are in that poor. And the income inequities, the average median income in a household is 47,000, and the monthly rate in an okay place is 1,000. So do the math. When you have to decide, you decide a food and a roof. take care of their kids. It's not sustainable. Only 5% of the people own business, there's only 5% of all the businesses in Philadelphia that belong to like small businesses owned by the people, not large corporations. So if you have someone that has the talent and wants to develop a business, it's a challenge. We have also affordable housing in a safe place, but no asbestos and no metals and no environmental hazards. That costs money. We have to make decisions. So access to transportation. You'll be surprised, I work in a crisis center and many of my patients ask me, can you give me a token? Because they don't have enough money for that. And food insecurity. And I will add like healthy food choices. Because you can have food that is cheap, but it's not healthy. Then you get cholesterol, diabetes, high blood pressure, you name it. Access to insurance. Only the people enroll more frequently, and there's more people that have insurance now. What is that, the right insurance? People that work, they tell me all the time, I cannot make these co-pays, these are very high. The deductible is very high. So, they have insurance, they have access to insurance, but it's not the best insurance. We have education, competitive education. I was concerned about the kids graduating last year. We saw that 72% of the kids graduated from high school last year, which was good. But we want to make sure that the kids have a competitive education. So when they graduate, even if they don't go to college, they learn the basics on money management, maybe how to get trained to join the workforce, how to develop or start a business. Who will mentor the kids? For me, my career was very difficult to develop, and I needed mentors. But I will highly would have appreciated to have mentors earlier on before I had to fight for it. But I feel for the kids. The kids has to be ready to face the realities of life. In the cultural Latin American groups, which obviously you hear my accent, that's my expertise. So we live with extended families, we take care of the elders, we take care of the kids. We live in highly crowded, houses. The undocumented people also live in highly crowded spaces. They don't have access to medical insurance. They might get access to Medicaid, but when they have an acute, severe medical condition, that one of the ladies that I met had when she developed a brain tumor, which was unoperable. The patients, they prefer obviously to have a physician that speak their language or access to interpreters that understand the culture. And by federal law, that's supposed to be the case, that people have the right to have an interpreter. And people don't know. There's lack of also of education to the community of their rights and what they have. But when you go to many of the practices, they don't have access to the language interpreting services. So those are some of the situation that we see in Philadelphia.
Okay, thank you.
Sorry for taking too much time.
Oh, no problem. Thank you for that. I would like to share a slight story and then ask this next question. I sort of uniquely live in the tension of both being on the bottom and the top at the same time. I'm a Black man, and so there's a threat to living in Philadelphia and the whole system just because of that. But I'm also a pastor of a highly visible church, So there's a level of privilege that comes to me. So here's my experience. Last year on April 20th, I was diagnosed with COVID-19. I took the test thinking I was just modeling good behavior, and lo and behold, I was positive. This was during the time when we didn't know a lot about it, and so I was absolutely scared. The guy on television was sick, and Tom Hanks and all them, and I was just afraid I was going to be like them. I was told by 4 different professionals 4 different things, and the information coming at me was strange. Today, I still have the antibodies. I was tested just last week, and I still have antibodies that are over 250, whatever that means, I don't know. Most people lose their antibodies. I still have them. But I've been told different things, and people are, about the vaccine. People are scared of the vaccine. This COVID-19 thing has everyone spinning. My question is, how has the manifestation of COVID-19 and the public health response made more visible the health inequities and health disparities observable in America? I choose to believe from my theological lens that the Lord, this is my language, my testimony, the Lord allowed me to get it because when I got it, it made news. It got a lot of people talking about it, and I was at least able to bring a lot of attention in our community and continue the conversation. But how has the manifestation of COVID-19 and the public health response made more visible the health inequities? Brother Johnson, you want to take that a little bit?
Sure. I'm a health care provider, and I, in addition to our work at Miriam Medical Clinics, where we provide care for people who do not have health care, who have inadequate health care, I also work full-time at an urgent care center. I contracted COVID-19, and I brought it home to my wife. Both of us were sick. She was admitted for 16 days to the hospital. She is still recovering. That was in November. And she still has residual effects. She is still undergoing therapy for her lungs. I recovered without any real sequelae, any real significance. But it allowed me, again, as Pastor Waller says, it allowed me some personal insight. It's different when you are sticking the swab up someone's nose and if someone is sticking it up your nose. It's a completely different experience. I had a total of 3 tests. The first one was falsely negative. The second one, it was indeterminate. They hadn't done the swab right. And the third one, which I really didn't like, turned out to be positive. But by the time I was positive, I had to negotiate. I had to navigate through a healthcare system, which I thought I understood. I had to become a patient in a system that I thought I knew. And having going through it gave me a new insight. And so you go to an institution, if you are a professional and you are educated and you have the means, the financial and other means to negotiate and navigate this system, it's completely different. But these hospitals have languages. They are huge edifices. These things look more like 5-star hotels than they do look like hospitals. So you can imagine someone who has limited English capabilities, and even with English, no medical linguistics to navigate this system. It makes it impossible. It is intimidating. And so what it brought out to me again was not even a matter of being educated or capable. This is an intimidating system, and I believe that it's to some degree meant to be intimidating, because when you have to pay your bill, you just pay it, you sign, you don't care. And if someone turns you away, you don't know that you have options. You have no idea that you have options to negotiate. You have no one to advocate for you to get those options. And so as a consequence, you end up with less than adequate care because this is intimidating. This is a very intimidating system.
And thank you for that. Speaking to that, Brother Ngari, I hope I pronounced it right. The cost of effectively managing the pandemic has affected healthcare systems and healthcare providers. In what ways is this observable? How has this impacted this system and how we provide from your perspective?
Well, it was, the word that's used in the industry is utilization, right? So there was much less utilization because people didn't go to the doctor for all their other conditions. So it was a very, very tough year for primary care doctors. People were afraid to come to the doctor. We responded pretty quickly by enabling telemedicine. You know, there was a kind of a stereotype in the industry that, oh, well, people won't use telemedicine. Well, it took people about 10 days to figure that out when they realized that was the only way to get to the doctor, except for people who didn't have a smartphone, except for people who were 85 and older. So yet again, even in a brand new situation, you find that the other structural inequities translated into a health inequity, because for a person on Medicaid who has maybe still a flip phone or another kind of a phone, doesn't have a smartphone, they couldn't do FaceTime with their doctor. So telemedicine was a good response, but again, showed us some of the weaknesses. The specialists have seen much less use. So the doctor side of the economy had a tough year. The insurance side of the industry had a good year because the insurance industry takes risk on total spending. So that since the spending went down, it was a profitable year. Now the enlightened insurance companies, and I think IBC did a good job of this. They took a lot of those excess profits and plowed them into the community. So we accelerated payments to doctors. We paid full rate for telemedicine and so on. So if you all pull together, you can make things happen. But that was the overall effect, was the spending on COVID care was much less than the care avoided. Now we're going to pay for this next year because people didn't get their cancer checkups and they didn't maintain, as Dr. Ortiz says, they didn't maintain. People go out of work, they let their prescriptions go down, or they did prescription splitting. So we're going to pay a price. There's going to be a tail for COVID in people's lives that we'll see next year.
Mm-hmm. Thank you for that. I am grateful that I pastor a church where we have people like Kim May in the church. And so we have a very robust response as a church to helping people know their numbers and keeping a conversation. At our church, every second Sunday, we have a health moment on Sunday morning where one of the members of the church, who is a physician, just talks about a health issue, just keeping it in front of people. But it is very clear that something is wrong in the system. And I know we're not supposed to ever tell somebody else how to do their job. But if you could advise the president, governor, or mayor on a key public policy affecting health inequities and disparities, what would you advise? If we've had this conversation, I'm going to ask each of you, you could pick the person and the topic. What would you advise on these issues? I'm going to ask that we go in our original order, Dr. Ortiz and Dr. Ma, then Dr. Johnson, then Ngari, in that way.
Okay, so if I had the opportunity, one of the things, there's several things, but if I had, are we talking about like COVID-19? We're talking in general, like now?
In general, you have the opportunity and a key public health policy affecting inequity. What would that be and what would you say?
So one of the things that I would like to say is education about the resources that are available. And an example of this is I had a summit with the prevention of veteran suicide many years ago, because I had a patient, you know, obviously. I was surprised when I connected with a veteran, a colleague, you know, friend, that connected me with a ton of resources, because there was a network of veterans and veterans advocates that were all connected, and they gave me so many resources, and I was so grateful. But as a physician, I didn't know and I didn't have any other way to find that information. So how can we centralize all the great resources that are in the community, in our area or at the national level, but in my case, more up in the regional level, so we can have access and start building those, connections and relationships, so our patients can benefit from this, community programs that are out there. So communication is very important. The other part is the medical records, electronic medical records, they are not integrated, because depends if you have a small practice or a large practice, you can pay for expensive medical record or with the cheaper one, and they're not integrated. I know of programs, there's some organizations that working in Florida and Minnesota that they have an application in which they integrate all this information. And their goal, and I find this very interesting, and I don't have any financial interest whatsoever, but it's very interesting because what they're hoping to do is to have the patients carry their medical records in the cell phone, which I know there's another things that, we have to make sure the security and there's a HIPAA compliant and all those things. So they actually provide phones to the patients that don't have phones, because we understand they are very expensive. So communication is very important for me, because the patients don't know necessarily everything that's happening medically, their medical treatments and the medical status. So coming from Puerto Rico after Hurricane Maria, living in a disaster zone, for me it's very important that people are connected with their healthcare professionals, so they can, even if it's virtually or through the phone, but I need to have that information because the patients don't have it.
Amen.
That'll be my ideal world.
Thank you. Dr. Ma?
Yes,
What issue
so
would you
if I have the opportunity to advise the administration, I think we first have to think what are the best ways to transform healthcare and reduce and eliminate health disparities. We can't really emphasize enough of social determinants factors. If people don't have a stable housing, and with the digital divide, that's already put them more disadvantaged to get the quality of care, to have a continuing follow-up communication with their providers. So if people are in poverty and they can't afford health insurance, so this will be put them in the disadvantaged condition. And also lack of these culturally, linguistically appropriate resources to build the program that could serve the population, that are also going to lead to the disparity. So if I have the opportunity to advise, build all these strategies and resources for these programs, I think we will have a chance to advance health equity.
Thank you for that. Dr. Johnson, you have the mic and the president is listening. What do you advise?
I listened to the president last night. I was very much encouraged that we're at least starting to recognize that this is a problem. Again, the healthcare system is sick, and one of the reasons it is sick is that we're playing a constant turf war. Physicians, dentists, nurses, podiatrists, insurers, hospitals, technology, pharmaceutical companies, pharmacies, they're all covering their own turf. No one wants to literally wants to share information because they're afraid that somebody else is going to get a corner on the market. After the 9/11, one of the things that became clear is that the FBI, the police departments, the DEA, all of these people had their own turf. They did not want to share information. Our healthcare system is fraught with the fact that we don't share information. And so what would need to be driven forth, and he talked about the infrastructure, we have to drive healthcare infrastructure. There was a time when no one had access to automobiles. People walked, they rode horses or whatever. And the infrastructure that made a difference, obviously, is the automobile. It became cheap enough for everyone to afford it. I believe that eventually the infrastructure of health informatics will make a difference. And if you look at it, it's going to be, as Dr. Ingar said, Angari said, it's going to be driven by some of the things that are already happening. Telemedicine is here. It's here to stay. And poor people will be better served by telemedicine, you don't have to have a doctor on every visit. A doctor doesn't have to be on every visit. You have nurse practitioners, you have physician's assistants, you have pharmacists who can help with effective medical management. You have podiatrists, you have dental hygienists. I still don't understand why I have to write a prescription for somebody who can't see his dentist because they got rotten teeth. These are technologies and these are integrations which must happen. So we need to integrate medicine. Robotics is going to change medicine completely. Precision, personalized medicine is going to help make choices. And so you can actually tell by the genetic makeup of a person, which antibiotic, which chemotherapy, which lipid profile, which hypertension medicine, the implantable devices for insulin management, implantable devices to monitor blood pressure management, genetic screening. So these are the things I would emphasize to our president. Get the infrastructure for healthcare on the mark. Make it a priority. Right now, this fee for service, if you don't have fee, you get no service. That should not be. That should not be. And we have to recognize that sick people are a drain on our economy. We need to keep them well.
Brother Ngari.
Thank you. I appreciate the title, brother, because I am not a doctor, and the people at 10 I'm going to slaughter me if I don't correct that. I am not a doctor. I didn't earn that title, so I'll be brother. That's better. I would say if I had one thing to say, it would be with the head of HHS or the president. And I'd say I'd zero in on something Dr. Ortiz said. She exposed one of the really hidden health inequities. And that is the fact that really almost everyone in the country has health insurance that they used to call catastrophic insurance. Even the Cadillac plan has high deductibles and copays. The difference is somebody's making $100,000 a year can afford the copays and deductibles, right? So if I had one thing to say, I'd say make it a condition that all the insurers had to do to make sure that at the low end, the first $2,000 of healthcare expense, if it relates to preventive, if it relates to the kind of medicine that's going to keep you from becoming diabetic, it's going to help you manage your hypertension, make sure that's zero or no copay, because it's a hidden inequity at the first few $1,000s that to a well-employed person is, it's a rounding error. It means a bunch of dinners they didn't go to. But to someone who's struggling with housing issues, those $2,000 are like a mountain. So that would be the one thing I would say. Focus in on that first couple of $1,000s, make it a requirement. The insurance companies will adapt. It's just like the car companies. Everybody said, oh, the car business will go out of business if the government makes clean cars the law. They didn't go out of business. We're business people. We'll figure it out. As long as you make it a level playing field, we'll figure it out.
Thank you so much for that. I have been given a hard stop of 3:20. And we have made it to 3:20. This has been so informative, and I want to thank all of you for investing your time. Dr. Bird, I thank you for allowing me to raise some questions, and I thank all of you for being in this conversation. So I am going to turn this over now to Dr. Malcolm Bird, who is the author of this experience. And those of you that are watching on Facebook, I want to encourage you to look out for more conversations by Dr. Bird and Philly Forum. And please continue to pay attention. The only way things change is if people raise their voices and stay connected and stay invested in our community. Thank all of you. God bless you. God keep you is my prayer. Brother Malcolm.
Wow. What an extraordinary experience this has been so far. Not only have we heard from the national leadership as it relates to the address and remedying of critical health equity and disparity issues, but the regional leadership of the most dedicated and competent leaders available to this cause. Dr. Waller, we want to personally thank you for effectively and magnificently facilitating the panel. So on behalf of Forum Philly, we are most appreciative of the powerful and compelling message shared with us by OMH's director, Roslyn Holiday-Moore. She has certainly demonstrated the wisdom and the appropriateness of her appointment by President Biden to compellingly articulate and lead the implementation of his vision for health equity and the administration of OMH. It is with particular gratitude also that we thank Frank Ingari and his extraordinary team that daily serve under the banner and purview of Tandine Health. And I want to acknowledge and extend specific kudos to Jermaine Bromell, the Associate Director of Population Health at Tandine Health, and his team of professionals who, behind the scenes, invested considerable time and skill to ensure that the viewer was served and well informed on this afternoon. We are confident that with their assistance in the convening of future forums, we'll continue to enjoy best-in-class and innovative approaches for achieving health equity and effectively addressing health inequities. I want to also thank Chris Rippey and his team at Carbon Square that worked with us even beyond traditional work hours to ensure that the thousands of those reached by our promotion of today's forum had exceptionally high quality, easily accessible digital graphics and accurate content about today's forum. Likewise, again, we thank Reverend Dr. Alan E. Waller, a friend and colleague of many years, who is a greatly admired and very influential faith leader that has profoundly impacted the Philadelphia region, and especially those of us who daily benefit from the ministry and the benevolence of the Enon Tabernacle Baptist Church. His moderation of our distinguished panel of health experts has established a new standard, if you will, for serious and meaningful dialogue about achieving health equity and the eradication of health disparities. We also had the distinct privilege of filling our civic wagons, exam rooms, and faith channels, if you will, with the passionate commitment and unsurpassed expertise of our subject expert panelists, Dr. Grace Ma, Dr. Michael Johnson, Dr. Natalia Ortiz, and Tandine CEO Frank Ingari. And I'm certain that we are better informed and even more committed to this important work. To add to the national perspective, we also were benefited by a thoroughly informed and remarkably resolved regional public sector HHS Executive Officer Melissa Hurd, who has already carved out a path for effective and far-reaching collaboration and partnerships, and to further complement the opportunities for making a lasting difference in the area of health outcomes for those we serve. I don't believe that I need to tell you how pleased we were to enjoy the important promotional support of 17 diverse faith-based and health provider organizations as collaborating partners that help to get the word out to the larger community. Lastly, but not least, I want to personally thank the promotional and media expertise of Forum Philly's own Ollie Lear and Denise Clay Murray, who were instrumental in ensuring that I have this platform to speak with you today. So it is if our collective hope that today's presentations have helped to better inform our ongoing preparedness to facilitate and improve the health outcomes of those we serve. Finally, we thank each of you who prioritized today's health forum by attending. We look forward to again partnering and leveraging our voices with you in the future. Thank you and have a wonderful afternoon.
Thank you.
Thank you. I'm going to pause our live right here. Oops. I think I am. Okay, my controls. Thank you, folks. I'm trying to get more options here for pausing the live recording. Okay, and now it is done. Again, Dr. Waller, Dr. Johnson, Ms. Holiday-Moore, I'm looking at Jermaine and Mark. I want to thank you all again for what I think was a very, very powerful health forum this afternoon. Alan, you're a bad man. You know how to get to the heart of the issues and speak to them in such a way that you're able to pull out the best from our health experts who are on the line today. Dr. Moore, Roslyn Holiday-Moore, so appreciative of you, not only keynoting, but choosing to remain with us for the entirety of this forum. We so respect and value the administration's decision to position you to affect the nation. We're just grateful to you. We didn't know that we were going to enjoy you for the duration of the program, but I'm so glad that we did.
Absolutely.
I know you're over time, but one more time, there's a gift of gab here. This was such a powerful discussion. And I also agree, Dr. Bird, that Pastor Waller, your facilitation was extraordinary. And the content that you were able to extract from the panelists, I have pages of notes, because the one thing I wish we had done better, and if I had known more, would have definitely extended an invitation in some fashion to connect a broader audience to this event. So many of the questions that you raised and answered are the questions that we're struggling with, and the resources that are being dispensed to address responses or to extract answers are not anywhere near hitting the mark that you hit today.
Well, I can assure you that we will post this on our Facebook page and our website so that it is accessible, but I didn't mean to cut you off. Go right ahead.
No, I was going to, then we can cross post or something and share it with the other regions, because I meant what I said. Yours is a forerunner. You were among the first to have a council, and others are trying to follow in your path. And one of the benefits we have is to make sure people can learn from the successes of others. And we definitely want to lift up your work. So thank you so much for letting me join and for letting me to linger and learn.
Absolutely. We're very happy you did. Brother Bromell, please, you certainly, please should make some observations, if you will.
Now, it was a pleasure to just have an opportunity to listen to the dialogue here. But I think, as we said early on, the real important thing is what happens now. I know that my company, Tandem Health, is interested in how we can help be a part of the solution in expanding primary care access, particularly in recognizing that's a big solution to the problem, to move us from being treatment oriented to having more preventative infrastructure in our community. So I certainly want to work with Pastor Waller and other faith leaders, and I know we want to work with medical leaders across all cultures to see how we can help address some of the need.
Amen.
Amen. Amen. And Dr. Johnson, you know, we have such a regard for your work down through the years as Christians in particular, and how that Christian virtue has benefited so many across the globe. And now back home again, how pleased we are that you're continuing your great work.
Well, you know, we stand on the shoulders of giants. We just, if it weren't for this community effort, it wouldn't work. So I just appreciate you making this happen today. Thank you so much.
Amen.
Amen, indeed.
Thank you so much. Malcolm, I really appreciate you, man. You're always on the cutting edge. So thank you for letting me be a part.
Absolutely grateful to you, sir.
All right. You all
Mark,
take care.
again, Mark, we're appreciative of the Philadelphia County Medical Society remaining committed to this effort and helping to facilitate its success. We're looking forward to the many other partnership opportunities going forward. Miss Moore, let me just share with you one thing that we are doing in Philadelphia, and that is we're doing an all faiths vaccination campaign during the month of May, culminating during the Memorial Holiday weekend, where we're wanting to serve as many underserved communities in Philadelphia and surrounding communities with vaccination availability. We have the cooperation of the city government mayor's office, who's working with us, 4 or 5 of the leading health systems in Philadelphia, as well as 3 of the major pharmaceutical retails, Rite Aid, CVS, and Walmart, and we're expecting others, and a load of faith organizations as well leading this campaign. And what we're envisioning is that the Memorial Holiday weekend, beginning on that Thursday through that Monday, we'll be up doing what we can to increase the availability of vaccination options. And then we'll bookend it during Juneteenth weekend of June the 18th through the 20th, also urging people to get those second shots. So this is an effort of government, the faith community, the health sector. We've invited the business community to help generate incentives for people to get vaccinated. And we're just very excited about it. And there's growing enthusiasm for this effort as well.
That sounds exciting. And I like the strategy of your book ending. I don't know if I hear a lot of people talk about that, you know, but there is a concern about the second shot. And so I'm actually, one more note that I'm taking my book here, because if there's a way that we can lift it up, and I'll definitely work with your regional office here to make sure that we don't lose visibility. We probably can help promote, if that would be of use to you.
It absolutely would be. We are trying to develop messaging as well as media collateral around the effort, and welcome all the support that your office can lend to this effort.
I can definitely do the promotional part, and I'll follow up tomorrow to make sure that we have a way of staying connected to that end. So as your information develops, then we can get it right out. Not a problem.
Absolutely. We're, again, very appreciative to you. And again, your availability to us at this level is absolutely exponential, if you will. And we're going to try to appropriate it well, so you'll not be ashamed of what we do here, but will always be a sense of affirmed in your leadership and complement what you do. And in fact, if the campaign became a national campaign, if that's going to push up the number of vaccinations in our underserved communities, we'd be very pleased.
Well, that's an interesting thought. I'm putting a pause on that one, not to commit, but that's an interesting thought.
Yeah, and it's a short window, we know, but fortunately, many of the people we serve don't need lengthy notifications. But again, coming from trusted messengers
Yep.
and providers that are proximate to their community, I think we'll get a great response to the campaign. And again, we already have multiple system commitments. And again, the mayor's office and all of his influence and force. Melissa Hurd has been working very effectively with us and many of her resources. So we're just confident that it will be most effective. And we're even expecting that we'll have a significant commercial business interest in supporting it and offering incentives for those who get vaccinated.
Well, one of the immediate outcomes, I had not had the honor of meeting Melissa before this forum, even though we work for the same employer. So it was really a plus, and I'm very pleased to have had that opportunity. And the follow-up can even be faster because she's working along with you in a more local way. So
yes, she.
I think
yes,
this is
she
like a win-win-win, a trifecta win.
Yes, absolutely. I like that trifecta. And by the way, unless I get in trouble, the National Medical Association, both the regional leadership and the city's local leadership is also working, partnering with us on that effort, as well as the Philadelphia County Medical Society that Mark Osterberry represents. We're expecting the support of Black nurses, and we're even working with Dr. Ortiz now in having significant support from Latinx health professionals as well.
And so when I mentioned that National Network for COVID Resiliency, I'm part of my homework from this is to see how Philadelphia and your regions are connected in that network, because I think we're working with many of the same partners, which is always a plus and a minus, because then,
Yes.
you know, resources aren't necessarily converging. To go to Dr. Johnson's point about how we need to think about the health of the infrastructure, just by sprinkling resources around, sometimes you minimize the impact. And so if we're
Yes.
all working with the same people, but in different environments, that's not getting us that return on investment that I would hope for. So I will definitely follow up with that, if not today, tomorrow, to make sure that we can see what's in place already that can be offered to you. And then definitely the commitment of lifting up your event.
Wonderful. And again, you have my pledge of support. Dr. Natalia, so happy that you were able to come back in again and get this additional time with Miss Helen. I'm sorry, I keep saying Helen. Miss Holiday-Moore.
Call me Roslyn. It works so much better. If you call me Roslyn, then we don't have to trip over all the names.
Well, thank you, Roslyn. You can call me Malcolm, please.
And if I could interject for 1 second, I'd be remiss to not ask a question. I know one of the things that I'm interested in seeing from this, Director Holiday-Moore, is how we can work with the Philadelphia Medical Society and people like Dr. Johnson to help build out primary care infrastructure in some of these underserved areas. And I'm just curious if there's anything you know about that's in the pipeline that might help us be able to build that kind of infrastructure across our region.
So I don't have the immediate answer that I would like to have in terms of, yes, here it is. But I had already made a note around the references to the infrastructure, because I recognize that that is pivotal, and I need to do a little bit more homework on that one. Okay. So it's not lost.
And I would
Go ahead.
No, and I'm sorry, I didn't mean to interrupt you. I would just add that we know, and I know even through Dr. Johnson starting his clinic was faith affiliated. We know that there's infrastructure in our community. The challenge is with different payers and even just the turf wars that I think was so eloquently spoke to, and it becomes harder to build a collaborative effort. But we think that we're at a point where people are willing to see how we can work collaboratively to help build infrastructure, and knowing that having more primary care is part of the solution around how we help address these needs and don't have the downstream costs to the health delivery system.
Yeah, your point's not lost, and it's complex and complicated, and at the same time it can be easy.
Yes.
So my tendency is look for the easy, which is why I want to be able, when I said earlier I was putting myself on mute so I could be a good listener, is because I love to talk. And I know if I'm not on mute, then I miss a lot of the points. So the mute button is my best friend during this pandemic. And I was listening. I intentionally stayed because I wanted to hear all of the voices. And that's why I think Pastor Waller did did a wonderful job of elevating the points. And so, as you can tell, I do prefer first names. So Jermaine, not to be disrespectful, because I'm sure you have a rich title, but part of what I think is important in terms of building infrastructure is getting the resources to people who are building these coalitions and really doing the work. And right now we have been handicapped, to be honest with you, in terms of how our resources have flowed from our space to communities. But we're not unaware of the need to look at that from a solution-oriented perspective. You're not the first one to raise the need around infrastructure. And I think it is fundamental to the sustained growth and potential of health and well-being for our people. So I will do the homework and I will get back to you. And if I don't, I am very open to you pinging me back and saying, but you said you would, and we're still waiting. Why are we still waiting? I come from New York City. And you know, in New York City, waiting is like a hot minute.
Yes. Yes.
And so I don't mean this to say, okay, thank you for that good question. I'll get back to you, and then you don't hear from me anymore. You're in between where I am and my home. I go back and forth a lot. So I want to be able to come through Philadelphia
Absolutely.
in a good way. I don't want to have to duck and hide. So I will get back to you, and I will get back to you with things that are concrete. Because in the immediate, if there are resources that we have, it may not be through the Office of Minority Health. It might be through another agency.
Sure.
And it's my job, as I see it, to make sure you are aware of that, or the pipelines that are emerging, or the conversations that are unfolding. Because
we do appreciate it.
Your voice should be there.
We appreciate it very much. Dr. Johnson, please.
One of the things that the Asian community, the Hispanic community, one of the things we recognize is, and of course in the Black community, you want care that you can trust from people you know. And
yes.
It's not about, I don't want to go to see a white doctor, but the lingo, the language, the body language, it makes a difference. In our time in Kenya, we learned Swahili, and it's important to speak in a language that people know. The care can be the exact same care, but if you speak their language, they trust it a whole lot more. And so for me, if the federal government's going to do anything, do something to invest in clinics like Miriam Medical Clinics that are in the community, providing care for people that look like them. Again, we've been going on for 8+ years now, solely supported by donors, and we're all volunteers, and people come to us because we look like them. Our outreach in the COVID, we were able to marshal the resources to provide COVID vaccination, but people come to us because we look like them. And so I think the emphasis, I don't know how you can do this, but if we can find a way to make a project like Miriam Medical Clinics easier for physicians to do. And, I know that there is an incentive with serving in poor communities. Well, if I can get doctors to serve with us to help get their loans reduced, that's tremendous. But we need people trust the care from people who look like them. That's just that's just the way it is.
And can I just make the observation that Dr. Johnson was a medical missionary in Kenya for over 20 years, leading his congregation here in Philadelphia and ministries because he and his wife were so passionately committed to delivering health care in spaces where it was not readily available. And I think he served there for about 20 years, Dr. Johnson?
That's correct.
And returned here to Philadelphia to continue the work in partnership with the local church and faith community.
Yes.
That's commendable.
Yes, and so we have to do that. We have been, and we've lost that as physicians. We got caught up in the fee for service, and that should not be where we are. There's nothing wrong with making money, but that should not be our objective.
Amen. Amen. Dr. Natalia, did you want to just share any final remarks before we conclude this conversation with Ms. Moore?
I agree with Dr. Johnson. It has been, in my experience, it has been a challenge to get the healthcare force to, volunteer because they are, and this is a topic that we didn't discuss, the physician burnout, working in the large hospitals, and some of them had decided to quit their jobs and transition and open their own private practices. But as we know, and Dr. Johnson has mentioned here, opening a private practice that can serve the community and that would, dedicate the appropriate time that the people need, like the old school type of, care that we love to provide. That's a challenge to do, and nowadays, to have a sustainable system, clinic that can provide that care. And I wish I knew the solution, to do that. And I wish I can myself open my own, clinic someday, but we've been forced to become employees because of the financial difficulties, including, the loans and the benefits and the malpractice insurance that is super expensive. And we had to protect ourselves because, in Philadelphia, there's a lot of lawsuits, as we know. So, if we can support infrastructure of the clinics that understand the community, I'm support of that.
I am struck as you're commenting, as much as we hear, I don't know of a forum before this where I've actually heard from physicians talk about the perspective of how to connect with the understanding of the community. We're hearing a lot about, from advocates for physicians or even like patients about physicians, but I don't know that we're hearing directly from physicians about the solution. So you see on the media the impact of the 24/7 tours of duty and the care and the challenge to the mental health and wellness and the strain of not having resources and those, but then to have the conversation focused on what is possible and how do we make what is necessary possible. I don't know that we've done that, actually.
But that'll be very interesting to do, and I can find you the physicians that will be very interested.
I'm taking a lot of notes, but I just wrote that one down because I'm like, I don't think I've heard this before.
Wow.
And you hear a lot of things, and this is my point about we hear the same thing over and over again, which gets us into a loop, but not necessary to a solution.
Yeah.
So thank you for that.
Again, thank you all. Roslyn, so much for the time, the level of expertise and influence that you bring to bear We're grateful to you. Look forward to, again, not only being available for the local work, but supporting you and your leadership on a national level. Dr. Johnson, again, my respect and admiration to you, sir, as a Christian brother. Dr. Ortiz, I'm so looking forward to our conversations on tomorrow. By the way, I think that Zoom link still needs to be sent, by the way.
Yes.
So hopefully that happens. Mark, thank you for your continued support of this effort, as well as the All Faiths vaccination campaign. Again, God bless you all, and thank you so very much.
Thank you so much and enjoy the rest of this day. Bye.
Nice
Thank
meeting you.
you.
Goodbye, everyone.